There we go. Okay. Thanks so much for having me. I'm Evan. I'm a clinical psychologist and at Mass General Hospital. I work primarily with folks who are caring for a loved one with a neurological condition. So today I'm going to be talking about the caretaker or the caregiver. Um, Dementia, a lot of these neurological conditions, they're not just affecting the person with that diagnosis, but they really impact the whole community, the whole family system, the relationships that are close. We're all impacted by this illness. And so we want to also talk about those who maybe don't have the diagnosis but are still really impacted by this illness. So why talk about caregiving and also why talk about stress and psychological well-being? Well, taking care of somebody, especially somebody with a neurological condition like a dementia, is really stressful. So over 50%, 60% of those who are in a caregiving role report high or very high emotional stress. And sometimes that even escalates to things like depression or anxiety. And this role is just marked with a lot of emotional, financial, and physical burden. There's a lot of responsibilities that are really challenging when you're taking care of somebody. And this stress is serious. A lot of times it can escalate, as I mentioned, to depression or anxiety. There's a high rate of people who report this stress and overwhelm that have thoughts of harming themselves. I also really want to highlight that a lot of folks who are in a caregiving role tend to neglect their own needs. So 27% of people in this role do things that deprioritize their own health. So they're not really taking care of their own body and their own needs as a result of the demands for the other person. And that actually leads to people having higher rates of physical illness. Family care partners of somebody with dementia have a 41% higher chance of developing their own physical challenges if they're not really addressing some of those stressors that come along with this role. Now, the good news is that all of this is very treatable. For a very long time, we've been developing interventions, and we really have a good sense of what works for things like stress, depression, anxiety. We have really good treatments. At this point, we really just want to make sure that we're able to get those treatments to the people who need them, and that the people who are in this caregiving role are willing to access these treatments that we know work really well. Now, I just talked a lot about stress and a lot about some of the challenges that come with taking care of somebody. I also want to acknowledge that there's a reason why so many people do this, because there's a lot of amazing things that come from being a caregiver. So almost half of people who are caring for somebody find it very rewarding. Not just a little rewarding or rewarding, but very rewarding. People get a sense of purpose from taking care of others. They learn new things about themselves. There's a lot of personal growth that happens as a caregiver. They report stronger relationships. So caregiving is really an amazing, positive experience that is also stressful. And so we don't just want to talk about the mental health challenges. There is a reason why people are in this role, and there's a reason why people thankfully continue to be in this role. I pulled a couple quotes from a book written by somebody who was caring for their parent. Um, and I just thought these kind of talk to some of the benefits of caregiving. So to care for those who once cared for us is of the highest honors. Caregiving often calls us to lean into love we didn't know was possible. And I think that's very true. Caregiving is an act of love, and it's a new way to show love that I think people get a lot of gain from. And in the heart of every caregiver is a knowing that we're all connected. As I do for you, I do for me. So reading these quotes, I feel like it kind of feels very spiritual. Like caring for another person is almost like a spiritual experience. And now to bring back stress. So we don't want to get rid of the caregiving role. We don't really want to alter the caregiving role because, again, we get so much out of it and we're doing such good for other people. We just want to find a way to take care of other people while also maintaining our own health and well-being. And it's a very played out analogy. I think a lot of people talk about this, but when you're on an airplane, they say, in order to put masks on other people and take care of other people, you have to put the mask on yourself first. And that is very true of caregiving and stress. In order to show up for other people, in order to get those amazing benefits of being a caregiver, we really just have to take care of ourselves. And that brings me to self-care, which I actually really dislike as a word. There was a book like 20 years ago, written by somebody named Gail Sheehy. She was a writer, a journalist, pretty well off. And she talked about the importance of taking care of yourself while caregiving and talked about how it was so great that she went to continue to go to Europe every summer and she would get in-home care for her husband who had dementia. And I was like, nobody can do that. Like that is like self-care is not lavish. We're not talking about, oh, you should treat yourself by going to the spa or buying something really extravagant. It really is putting that mask on yourself to make sure that this role is not impacting your own physical health and that you can continue to do it. So I don't want self-help to feel like, oh, I'm telling you to, you know, go to the spa. If you want to do that, fantastic. But really, we really just want to take care of our own health. So I like this acronym of Plys as a way to think about self-care. So the first one is treating your own physical illness. So if you have a medical condition as a caregiver, make sure you're getting care for it. You don't want to delay treatments like, I'll put off physical therapy until things, die down and they don't. We really want to continue to prioritize our own health. So make sure you're going to the doctor, you're getting the right treatments you need for your own physical illnesses. Second is eating balanced. Food is really the thing that it's very tied to our mood. And it also is tied to our sources of energy. Those are things we need to inhabit the caregiving role. So eating a balanced diet is very important for our own health and well-being. Avoiding mood-altering drugs, substances, even like alcohol, that can alter our mood. We want to make sure that we're not engaging in behaviors that reduce our health, especially when we know we're in a role that has the potential to be stressful. Sleep is so important. And what I hear a lot from my clients is they're like, at the end of the day, once my loved one goes to bed, that's when I do all the activities for myself. That's when I watch the news, get on my phone, scroll the internet, and then it impacts their sleep and it snowballs. So we really want to be protecting our own sleep pattern. We want to make sure that we still wind down. So things like the news, things like screens, try to find another time in the day to use them other than right before bed. Because getting a good night's sleep is really one of the most important components of putting that mask on first for yourself. So we don't want to do things that disrupt our sleep cycle. And the last thing is exercise. Exercise is really important. You don't have to go to a gym or get on a treadmill. Walking 20 minutes a day, walking up the stairs, getting that blood flowing, getting that heart pumping is kind of a way I like to think of it uh, as we get that heart rate up and we're circulating all the good oxygen in our system, we're cleaning out some of those stress toxins. So it's a way of detoxing yourself to get exercise. and just 20 minutes a day. So all of this stuff is probably not new information. You probably didn't need me to tell you, oh, you should sleep well. Of course you should sleep well. We all know we all want to sleep well. This is all easier said than done. So I want to talk a little bit, just a little bit, about what gets in the way of self-care, of these types of activities that, again, are just maintaining our own health and well-being. One of the things that I hear a lot in especially from caregivers is we internalize a lot from the media and also from our families about what we quote unquote should be doing as a caregiver. And a lot of times these are unrealistic, these set unrealistic expectations for ourselves. So one of the things I hear a lot from my clients is they'll be like, my grandmother took care of my grandfather, and she was amazing. She was so selfless, and she cared for him 24 hours a day and never complained. She never looked upset. And I'm like, is it possible that she just didn't want to complain about her marriage to her 10-year-old granddaughter? Like, that doesn't mean that it was a perfect situation where she was just happy and not taking care of herself. Like, we all need to maintain our own well-being. But a lot of times these caregiving roles, and we can talk about, and it's a very gendered experience, but this the social norms, the what society and the media tells us that we should be acting in this caregiving role is often neglecting our own needs, and that's simply not true, and that's not the healthiest way to go about it. A lot of times what that does is it sets these beliefs about what we again should be doing in this role. Now we're applying it to ourselves. One I hear a lot is, well, I shouldn't take care of myself because I'm taking care of this other person. They're more sick than I am. Maybe, but that doesn't mean that you don't deserve the care you need. And again, you have to put that mask on first. So um, it is part of the process to take care of yourself. Another one I hear a lot is, I'm the only one who can provide care, or no one else is going to provide as good a care as I am. And you might be 100% right that you know more about your care recipient than anybody else. And there are professional caregivers, and they can also provide care. And it doesn't always have to be perfect. And so those are some of the things that really get in the way, that those are the stories we tell ourselves that make us not do those things, like sleep, like exercise, like take some time off. These kind of narratives that we tell ourselves kind of keep us stressed. I also want to say that there are other very real resource issues. Like, you only have 24 hours in a day. You only have a limited amount of energy to yourself. We only have a limited amount of finances in our bank account. So there are also barriers to some of these self-care activities. Same thing with health issues and depression. But those first two things around those beliefs and those thoughts that we tell ourselves, that's often in therapy, the kind of work that I do, where we're really analyzing those and breaking them down and finding ways to create narratives that make us healthier and make us better caregivers and make us better able to appreciate all those amazing things about this life journey, because there's so much to gain from the caregiving role, and we want to be open to it. And so our mental wellness is what opens us to it. So last thing I'll say is I developed this clinic at Mass General where we provide therapy specifically for folks who are caring for someone with a neurological disorder. So our clinicians are trained. Many of them are actually learners who are supervised by licensed providers. And we really think about therapy specifically for the context of caregiving and neurological illness. So this QR code will take you to our website. Above it, there is a email address that I would love to circulate. We have a group that's starting next Thursday. If we don't get enough people, we might push it back another week. But we have a lot of group offerings. We have individual offerings. If it's something that you think you would benefit from or somebody that you know might benefit from, we'd very much appreciate you sharing that and would love to work with you at a group. Thanks so much.
All
We'll
right.
stop sharing.
Thanks so much, Evan. I just wanted to let you know there was an audience member who was really interested in the book that you mentioned.
Oh, great.
So she just asked for the title.
Great. I will put that in the chat.
All right. Thank you so much. Such wonderful and really important information. So we're going to move next to Dr. Ramirez Gomez. Liliana, take it away. Oh, you're muted.
Okay.
Okay.
Hi, good evening, everybody. Thank you for being here. Um, I'm going to continue with the topic that we are developing tonight, and I am going to speak directly about one intervention. And this is only one example of different things that we want to do to help our caregivers. I am a neurologist, and I specifically take care of patients living with dementia. One of the many types, it could be Alzheimer's dementia or vascular or frontotemporal or dementia with Lewy body. There are different types. But whatever the condition is, usually they have someone that cares for them, comes with them to their appointments, keeps track of their medications, coordinates the care. And these we call the family caregivers because they care. Sometimes they could be friends as well, because sometimes people don't have any family or family are far away. So the caregiver role can be provided by different people. And it doesn't mean necessarily that the person with dementia is living at home. They sometimes also are in a nursing home or an institution where they receive some care and support, but they still have someone that is paying direct attention to their needs and their care. So I speak to you as a clinician and also as a scientist who wants to make things better for the patients that I take care of and also for their families. And I am going to share with you an intervention that has been developed by a colleague in psychiatry that is addressing some of the needs of the caregivers. And as Dr. Plys already explained, the caregivers go through a world of emotions, feelings, and experiences. Some of them are good, and some of them are more challenging. And how we navigate this journey that the family members and the person living with dementia go through together, it's important. And this particular intervention is called mentalization, mentalizing imagery therapy. And many of you perhaps have heard about mindfulness interventions or relaxation techniques, different things that we do to take care of our well being and also be in the present moment. And mentalization is one step incorporating these type of techniques and includes being aware of our feelings, our thoughts, desires, needs, our emotions, our goals, and also understand the other person feelings, thoughts, desires, needs, and goals. So it's not only like putting ourselves in the shoes of the other person, but it's also understanding where they are coming from And as you could imagine, for example, in a person living with dementia, sometimes could be more difficult to express their emotions and their feelings, and it comes out like frustration, screaming, or being irritable or upset sometimes, or trying to say one thing but meaning another one. And one common example would be that the patient living with dementia says, I want to go home. I want to go home. And the caregiver says, but mom, we are home already. Don't you recognize this is your house? And what the person with dementia is saying is that maybe they are not feeling comfortable due to whatever reason. And that's the job of actually the caregiver, to trying to interpret what is it that they are trying to express. What is that they are not feeling comfortable right now? If it's that they are in pain, or if it's that they are feeling anxious or nervous, or what could be the cause. But sometimes trying to understand where the other person is coming from, or what is behind that attitude, that behavior, is helpful, not to feel attacked or upset, depending on the situation. And with my colleague who developed the mentalizing imagery therapy, which combines mindfulness and the mentalization through exercises that guide us through our imagination and through relaxation techniques to try to focus on our body, how we are feeling at the present moment, what is happening, being aware. That mindfulness of feeling and being in the moment, of absorbing without judgment. And our imagination that helps us put ourselves in the situation where the other person is coming from, to try to understand what's the reason behind that emotion, that feeling, that behavior, etc. So this is a set of sessions in which we teach the participants how to go through the exercises. And what we have found is that this set of exercises and practices, which are guided by professionals, have shown that in research settings where we compare people that do the intervention, the mentalizing imagery therapy, compared to the support groups. And here in this graph, the numbers go negative below, which means that the lower the bar, the bigger the effect. And what it shows here is that people that participated in the mentalizing imagery therapy had reductions in depression compared to the group that participated just purely in a support groups. But also there were decreased in symptoms of reductions in symptoms of anxiety and stress. And we have been able to publish this in academic journals. And we also found not only that there were reductions in stress and anxiety, but that there was an increase in positive psychological traits that overall would help us feel better, improve our well-being, and even feeling happier. And people who participated in the mentalizing imagery therapy had increase in mindfulness, in self-compassion, and also feelings of happiness. And I just show you this as an example of how we can create different interventions. Doctor, please share some ideas of how good sleep, good eating, healthy lifestyles could help us preserve our well-being, and also additional things that we can do. And this is something that we have used in the clinic. When patients come to us, for example, in my clinic, and they take care of their family member living with dementia, sometimes we share these opportunities to participate in groups like this, and that's what we have found in the results. More recently, because we want to be able to expand this and be able to provide it to more people, we have been able to develop mobile technologies like applications that you have on your phone, and that you can just download the application, click, and get the content, and you can listen and practice on your own time during the day and as much as you want. So we have developed menu of options with this intervention already customized in 4 weeks, where people are able to learn this relaxation practice and also learn about caregiving skills, how to manage different behaviors such as anxiety, sometimes agitations, or when they don't sleep well at night, etc. And also, there is a function in which there is a chat group in which people can also chat with other members that are participating in the groups and give support to each other, discuss topics or situations that they are going through. I I am a Latino physician. I am from Colombia, and I really care a lot about people that don't speak English as a primary language. And the reason is that we have a lot of population in this country and here in our region who don't speak English as a primary language. And we also want to have opportunities for them to be able to take advantage of these interventions that could provide benefits. So, as a first step, and hopefully I'll be able to translate this and develop it into different languages, but first started in Spanish. We have been able also to develop this application in Spanish to provide to Spanish speaking family members that care for a loved one with dementia. And through this, we are able to provide opportunities for them for relaxation, for well being, to learn tips about caring for someone living with dementia. We are also able to conduct research because we not only want to provide opportunities, we want to learn how we can do things better, what other things we can do to help the people that are going through this. So we are also doing research with the idea of improving these opportunities and making it every time better. So um, there are different types of research we are conducting that we can discuss for people that are interested. But this is an example of things that we are developing and that sometimes we offer spurs in research as we tune and improve and make it available for a larger group of people and a bigger audience. And with that, I want to thank you and I leave it with my colleague, Dr. Jean Yu.
Thank you so much, Liliana. So it's such a wonderful example of like health services research. I know a lot of people often think about clinical trials, but this is also a different kind of research, which is entirely different, that's focused on the caregiver and, developing some really important interventions for them. So we're gonna go next to talking about neuropsychiatric symptoms. So let me share my screen. So just remember, we're also going to have, does that look good? Just want to make sure it's good for everyone. So we're also going to have a Q&A as well after my presentation. And also we're going to have a little bit of a survey just so we know that things are going well and these are topics that interest you. So also kind of think of some questions that you might want to pose to Liliana, to Evan, and me regarding what we discussed today. So neuropsychiatric symptoms, simply kind of psychiatric symptoms that are rooted in the brain that you may see in your loved one who may have dementia. So these are some common ones: apathy, depression, and anxiety. So depression and anxiety may be things that you've heard a lot about already. Apathy, perhaps, if you have someone that you're caring for with dementia, it's a really kind of deep lack of interest, any motivation, any initiative. So it is a symptom that can occur in patients with dementia. They just sometimes when I talk with their caregivers, they may say they just don't want to do anything. They're just sitting. Perhaps they're watching television or they're just sitting there not even paying attention. They don't seem to take any initiative or interact with people, and they don't seem to have any desires. And it's very, very distressing. because they're also not interested in self-care. So the other psychiatric symptom that very, very common at all different stages of dementia. It can be in the mild stages. I mean, it can be even before you're officially diagnosed, but it can be in the mild stages as well as kind of the moderate stages. But a lot of sadness, especially in the early stages, it may be because in part you kind of understand that you're losing function, that you understand that there's something changing about you, and it causes a really deep sense of loss, a lot of sometimes frustration, sometimes panic because you're losing control. There's also, of course, anxiety, just worry, nervousness, fear that is associated also with dementia, very common. So what can be really, really difficult are behaviors that can happen in the person with dementia, agitation and aggression. So they may become agitated because they kind of have or have more difficulty kind of understanding their environment, understanding kind of cause and effect, and they're not as powerful as they used to be or able to manage and control their environment. And so they can lead to agitation. So Liliana mentioned that they want to go home, for example. If it's dementia has progressed to that level and they can't recognize where they are and they just have a simple desire to go home, it could be related to many things that the care partner often tries to figure out. But it can lead to agitation, especially if it's at night and or during the day, and you don't have the ability to just kind of let them go, or maybe take a walk with them or something. If they have to stay in the house and they're unable to do what they think they need to do, then they may get agitated. And I don't know how many times I've had kind of conversations with family who become really panicked because they're not quite sure what to do. There can also be physical aggression too. And often it's maybe around care. So patients may have difficulty being washed, being showered. If it's also there's this, it entails a little bit of a boundary breaking because someone's in your personal space. You may need to be washed and your clothes taken off, and your husband, who you're not, who typically doesn't do that for you, is doing it, and it can be very, very uncomfortable, and it could lead to sometimes some kind of slapping or hitting, or it could lead to verbal outbursts. That is also very, very difficult because how do you manage that? You want the person to be clean, you want them washed, and yet the cooperation is difficult. The other symptom that can happen is what's called sundowning. And it's called sundowning in part because it typically happens in the late afternoon, early evening, and there's a pattern of agitation and confusion. So the person, it may be, again, due to various things. One of the things that can contribute to that is just fatigue from a whole day of it could be activities or it could be kind of inactivity, but it can lead to agitation. And again, it's um, families and care partners can be really confused as to what to do during those moments. So these are some symptoms that can be a little scary. We call them in psychiatry, of course, kind of psychosis. They're psychotic symptoms because they're kind of outside the norm of what persons without either serious mental illness or dementia, they typically don't experience those things. So, for example, hallucinations that can be both visual, meaning you see things that are not there, or it could be audio, where you hear things that may not be there. There are also things like tasting things or smelling things that are also hallucinations too. You can also have delusions, and sometimes they're confusions, but it's defined as a false belief that a person just uh, can't be reasoned out of, believes it's true. So, a delusion or a false belief that you might encounter in persons with dementia, often in my clinical experience, is that they may think that people are stealing things from them. It could be for various reasons. One reason that could be happening is that because their short-term memory is impaired, they may be placing things in various locations, but they may not be able to remember. And when that happens, they may kind of conclude that it's because someone's taking it from them or someone is, stealing it from them. So that may be called a delusion because they have this belief that's not real, and it's not something that can be reasoned out of them. Sometimes the family members try to do that, which is reasonable. You might do that if there was somebody who didn't have dementia, who had those beliefs. But in someone who does have dementia, it's because they're really not capable or they're too cognitively impaired to recognize that that's not true. So there's a very common form of delusions called paranoia, where you believe that there is someone who is may harm you, or we use that phrase in quotations out to get them. So paranoia also can occur in dementia as well. Some of the examples, a patient believed that a neighbor who lived next to him, right next door, was trying to harm him by he felt that the neighbor was looking into his windows and that when he heard creaks and noises in his house, that it was his neighbor trying to get in. So he was in actually an kind of an earlier stage of the dementia, but he had this really very disabling paranoia, which kept him inside the house because he was really afraid to leave. So when we talk about kind of how to manage these neuropsychiatric symptoms, often what we try to do is counsel families to think about behavioral management if it's not too, I guess, disabling or if it is not causing kind of safety concerns for the patient and the family members. So there are kind of behavioral management things that you could try first. But then things like hallucinations, delusions, and paranoia, in addition to thinking what are some environmental things that could be contributing, we also want to think about medications, depending on the impact that
Por
it's
esto,
causing.
tenemos que pensar
There
sobre
may be
medicamentos
hallucinations in
y el
patients with
impacto que
dementia
puede estar
that is
causando.
not causing a lot of
Ahora,
distress in the
puede
patient,
ser de que haya alucinaciones
or
en
is
pacientes con la
disabling. And
demencia
sometimes,
que no causan
in
mucho
mild cases,
problemas
they
en
don't
el
necessarily
paciente,
have to be treated.
pero a veces es
But
bastante.
in cases where it is really distressing, it's causing behaviors that are, putting the patient's safety at risk, then medications can be effective. What I would
Y,
say is that they don't necessarily get rid of the
ah,
hallucinations or delusions
pero quiero decir de
completely,
que no
but they can decrease the
necesariamente los
intensity
medicamentos, hay
and they can
medicamentos para ayudar, pero no
also
eliminan las
address the
alucinaciones,
behaviors that
pero
might be
pueden
really troubling.
disminuir la intensidad de ambos, de estos. Y también pueden tomar cuenta de algunos otros.
Oops. Okay. So I just kind of wanted to present a little bit of a vignette, just to kind of put it in a concrete, make it an example of a person. So an elderly woman with Alzheimer's dementia, the anxiety and sadness, again, very, very common, kind of in the early stages, as they recognize and experience the loss that they're facing. Insight is still there. They know they're losing their memory, their ability to do things independently. That's really, really a big one. You're used to being independent, and now you're depending on your spouse or your children. And because they lose confidence in ability to kind of engage in conversation actively, they become more withdrawn. Sometimes they're embarrassed because they perceive that others do not perceive them as they were. And as the disease progresses, there may be behavioral issues, like I mentioned, kind of agitation later in the afternoons. And sometimes they go to many persons with dementia can be cared for at home, but they may also go to a daycare center where they might get some monitoring as well as some social activities, as well as give the caregiver, some respite who has some time to kind of refresh themselves and a break from the kind of the stressors of caregiving. And as the dementia progresses, there can be the anxiety can become restlessness and pacing, and irritability. And in these cases too, the medications can be helpful in kind of decreasing the irritability and decreasing the restlessness. That can be really distressing for the person, as well as really, really distressing for the caregiver as well. So these are more kind of later stage symptoms in somebody with moderate to moderately severe dementia, in my experience, where they're unable to recognize family members. So there are cases where they're not able to recognize their husband, who is the primary care partner. That is incredibly distressing, of course, for the care partner, and also very scary for the patient because they're living with someone that they don't recognize. And in some of my clinical experiences, it's not, once they're not able to recognize their care partner, they're not able to tolerate them because they really, cause a lot of fear. So that can be really, really difficult. So in terms of kind of managing, it's really, really useful to have a care team. So it may be a primary care physician, it may be a neuropsychiatrist, it may be, of course, a neurologist, a psychologist, who you may be seeing individually or you may be seeing in a group setting. And in any cases of kind of agitation, it's really also important to rule out medical causes, physical causes. So often what we do when there are kind of acute cases, kind of cases of agitation that arise suddenly, we make sure that there isn't some sort of medical cause like an infection that may be causing the agitation, for example. So that's always kind of the first thing we try to do. In terms of kind of managing behaviorally, kind of approaching with empathy. So that can be, of course, easier said than done when you're really caring for someone kind of 24/7. Your patience may be stretched, and your energy also may be stretched. But what's true is sometimes when there is kind of angst and irritability in the caregiver, that emotion can be transferred to the patient as well. So that when often the clinicians are thinking of managing patients, we're thinking of really the caregiver as well as the patient together. And as we mentioned before, kind of understanding the environmental things that might be contributing to feeling uncomfortable. Is the patient kind of in pain? Did they have a poor night's sleep? Are they fearful because they're seeing something, and they're not necessarily verbalizing that to you? So trying to think about other things that could be contributing are really important. Behavioral management strategies, always important to do before thinking of medication, although medication in really severe cases may be really necessary. So these are some other things to think about. An environment that's really, really too stimulating also can lead to kind of agitation and irritability. So making it comfortable, kind of low energy. Care partners kind of know their loved one really, really well. So knowing what situations, what environments make them comfortable and what can kind of lead them to a little bit of irritability and is very useful. The other thing is, often older adults with dementia,
Otra cosa es de que personas
they
de
don't
tercera edad
have
con demencia
kind of stimulating activities that they can engage in. So there are some interventions that have been developed where the caregiver and the patient kind of work together. The caregiver kind of identifies things that interests the patient, kind of can engage them, that they pay attention to. And so this intervention identifies that and then trains the caregiver to, in a kind of regular way, engage the patient in these activities. And the studies of this kind of intervention have shown that it does decrease agitation. And then we try kind of last resort, when the symptoms are really severe with medications, which can be helpful. All right, so that is my portion. So we're going to go next to a question and answer session. We really would love to answer any questions you have for the three of us. And so you could either come off mute and